LSVT treatment is built on 3 key strategies. Think of them like building blocks for a building. These include the target, which is to increase vocal loudness, which is achieved through the mode or intensive dosage and high effort, and the calibration strategy is to recalibrate the sensory feedback system to monitor vocal loudness. Today I will be discussing the following changes as a result of the LSVT program, which include the voice mechanism, increased loudness, and changes in brain activation. The goal behind LSVT treatment is to think loud in order to increase vocal effort to sound louder. When producing different pitch levels of the vowel ah, this exercise was shown in studies to improve laryngeal system functioning and jaw coordination. In children with dysarthria and Down syndrome, the tongue tends to lower with the jaw as it opens, so this causes vowels to sound more neutral. So vowels like ah may sound more like One study found that in both the Down syndrome and cerebral palsy groups that there were increases in single word intelligibility, increases in vocal intensity, and increases in vowel duration. However, in only the Down syndrome group, there was a growth in acoustic space. The same study theorized a few reasons why the cerebral palsy group did not show growth in acoustic space. One reason is individual differences, including age, diagnosis, and severity, which influenced variance in responses to treatment. Another reason was that they needed to test more vowels, because the only vowels tested in the study were E, U, and Ah. Studies have shown that there are also changes in brain activity as a result of LSVT treatment. One study found that changes in brain activity in children with cerebral palsy occurred because this treatment takes advantage of activity-dependent neuroplasticity, and it involves intensive treatment, repetition, sensory feedback, and saliency. The same study that analyzed changes in brain activation included pediatric participants. The methods used were to implement LSVT for 4 weeks, followed by 12-week maintenance, and fMRI was used to analyze changes in brain activity to compare pre- and post-treatment. The results showed that post-treatment fMRIs showed an increase in the use of auditory and somatosensory feedback systems for self-monitoring compared to the feed-forward system. The efficacy for hypokinetic dysarthria and Down syndrome has been shown to be statistically significant and showed positive changes observed in post-treatment and at follow-up. These changes include improved single-word intelligibility, increased vocal loudness, gains in acoustic vowel space, and increases in average vowel duration. The positive changes in the Down syndrome group were not seen in the cerebral palsy group. While there was an increase in average vocal intensity in the cerebral palsy group, these increases were found to be not statistically significant. So while there were increases in the average vocal intensity of children with cerebral palsy, it is not certain that these changes can be attributed to LSVT treatment. This just shows that increasing vocal loudness can be a behavior that is trainable in children with cerebral palsy, but we aren't certain yet if these have a large role in increasing vocal intensity. In summary, the goal of LSVT treatment is to increase overall loudness of speech, and present studies have indicated that LSVT affects the voice mechanism, perceptual characteristics, and brain activity. Increasing vocal intensity can be trained in patients with spastic dysarthria and cerebral palsy, but results in studies were not statistically significant, so they cannot definitely be attributed to LSVT treatment. LSVT treatment is then used more commonly for hypokinetic dysarthria.